Welcome back to the deep dive. Today we are taking out the scalpel, so to speak. We're doing a critical incision into how we actually create and use systematic reviews and meta-analyses. We're looking at some important new guidelines, trying to stop what the authors call cookie-cutter science, especially in fields like, say, clinical urology, where bad evidence has real consequences.
Yeah, it's an intervention that's really needed. And here's the context. Systematic reviews, or SRs, they've just exploded. They're becoming the main way research gets published.
Right.
Maybe we should quickly define those terms, just for clarity.
Good idea.
Okay, so a systematic review, that's the whole process. Rigorous, methodical, finding, evaluating, and synthesizing all the relevant evidence on a specific question, trying to minimize bias.
Got it.
And then the meta-analysis is the next step, the statistical part. You take the numbers, the quantitative data from the studies you found, pool them together, and get a single weighted average result.
And that's where this huge red flag pops up, isn't it? Just looking at the numbers. Our sources show the number of systematic reviews hitting PubMed. Well, it jumped almost 5 times between 2010 and 2020. Just think about that speed.
It's genuinely staggering. We're now seeing something like 60,000 systematic reviews published every single year.
60,000.
Yeah. And compare that to new randomized controlled trials, RCTs, the primary research, we only get about 25,000 of those a year. So for the first time, the synthesis, the reviews, are way outstripping the creation of new data.
That kind of inflation.
Yeah.
It just screams quality control crisis, doesn't it?
Yeah.
When something gets that common that fast, you have to ask, is it just easier now or are the incentives kind of skewed?
Well, it's really both, and they feed each other.
Yeah.
These new guidelines point to 2 big reasons for this low-quality, high-volume issue. First, it's institutional. SRs are incredibly cheap to do. Yeah, you don't need much equipment, no lab, very little funding compared to, say, running a big clinical trial.
So less money involved means you skip the usual gatekeepers, like the big funding agencies, the intense institutional reviews.
Exactly that. The usual checks and balances that push for rigor in primary research, they're often just not there for SRs. And the second issue is the method itself. It's very, very formulaic.
Right.
The steps, protocol, search, screening, extraction, they can look almost identical whether you're reviewing, I don't know, cancer drugs or like behavioral therapy.
That's where the cookie cutter thing really hits home, isn't it? That recipe book feel. And you mentioned software like Rivman. Does that make it worse?
It can, unfortunately. It's designed to help, obviously, but it can sometimes lull researchers into thinking, oh, I just plug in the data, follow the template, and boom, valid science.
The result is, well, maybe a lot of papers getting published that aren't really adding much. More for the CV than for science.
That's the concern, yeah, padding the CV rather than advancing the scientific record. So the goal of these new guidelines is to cut through that noise, focus on the really common, really damaging errors in analysis, reporting, interpretation.
It sounds like step 1 is just basic housekeeping, almost.
Yeah.
You've got to follow the existing rules first.
Absolutely. Things like PRISMA for intervention reviews, Moose for observational studies. These aren't just suggestions. They're the basic requirements, the structure needed to prevent things like cherry-picking data and to make sure everything's transparent. If you're not even following PRISMA, your review is already shaky.
Okay, so let's get into the biggest challenge they seem to be tackling. Because this is where that formulaic approach really falls apart, right? Heterogeneity. What exactly is heterogeneity, and why does ignoring it wreck the whole meta-analysis?
Okay, heterogeneity. Simply put, it's when the results across the studies you're reviewing vary more than you'd expect just by random chance, by sampling variability. If every study was identical, same patients, same methods, the results should only differ because of, well, statistical noise.
But clinical reality is never that neat, is it?
Never. Usually, the heterogeneity, it's caused by real differences, substantive differences. And this is where you need actual clinical judgment, not just a checklist. Were the patients different? Was the dose different? Was follow-up 6 months in one study and 5 years in another?
I see the problem immediately. If you average, say, a study with a huge short-term benefit and another study where that benefit disappeared long-term,
Exactly.
the average shows a moderate benefit, which isn't really true for either time frame. It's just a statistical artifact.
That's a perfect illustration. The critical mistake is when people see that clinical variation, that dissimilarity, and they just pull the data anyway. They force these different studies into one statistical result, and when you do that, the resulting average becomes, and this is a quote, essentially meaningless, or just plain invalid.
So how do researchers avoid that trap? It doesn't sound like the answer is just more statistics.
No, it's definitely not. It's more thinking, more critical evaluation. The right response when you see high heterogeneity isn't necessarily to jump straight to some fancy statistical model to adjust it. It's to step back and try to understand why the results are different. Dig into the patient differences, the treatments, the study designs. What are the causal mechanisms behind the variation?
You need to investigate why study A got one result and study B got another, not just average them out.
Precisely. Don't just mathematically smooth it away. Understand it.
Okay, this is where it gets really interesting for me. The guidelines aren't just about interpretation. They're actually challenging standard statistical tools, like the I-squared statistic. What's the issue there?
Yeah, this is a big one. It really pushes back against, well, decades of standard practice. So I-squared, it's the go-to stat people use to quantify heterogeneity. It gives you that percentage, right? Tells you how much of the total variation is supposedly true heterogeneity versus just chance. 0%, none. 75% high, etc.
Seems useful. Simple number.
It seems useful, but the guidelines strongly recommend avoiding it. Why? Why ditch I-squared?
Because, and this is the crucial flaw I-squared, is highly dependent on sample size. As the number of studies in your meta-analysis grows, and as the size of those individual studies gets bigger, I-squared automatically tends towards 100%.
Wait, really?
Yeah, regardless of whether the actual clinical differences between the studies are large or small. Unless there's absolutely zero heterogeneity, bigger studies will push I-squared up.
So you could have, like, 5 huge, really well-done trials, all showing a pretty consistent benefit. But because they're so big, the I-squared comes back really high, suggesting lots of heterogeneity, even if clinically they mostly agree.
Exactly that scenario. The source material actually shows this visually large studies all pointing towards benefit, but the I-squared is still high just because of their statistical power. So if you only look at that I-squared number, you might wrongly conclude the results are inconsistent or the pooled average isn't trustworthy, even when clinically they're pretty solid. Wow. That's misleading. The statistic isn't reflecting the clinical reality anymore. It's being driven by the study size.
Precisely. The tail wags the dog, as you said earlier. So the key takeaway here from the guidelines is vital. Deciding whether to pool data, how to present it, that has to be driven by clinical best practice, and a really critical look at the data itself. Not just relying on one potentially misleading number like I-squared. The most important step. Look at the forest plot. Look at the results of each individual study visually. Does pooling them actually make clinical sense?
So what does all this mean for you listening to this, maybe reading these studies or guidelines based on them? It really reinforces that meta-analysis can't just be this cookie-cutter science. It demands real thinking, critical evaluation, not just following a formula.
And that leads to the final point, a necessary shift, I think. Systematic reviews have got to move beyond those vague conclusions that just say, more research is needed.
Oh yeah, that phrase, the ultimate cop-out sometimes.
It's become almost meaningless filler, hasn't it? It's easy to say when you don't know what to make of the heterogeneity you found. But if your review concludes that things are uncertain, that uncertainty must be specific. It has to be directly informed by the data you just analyzed.
So instead of just more research needed, it should be.
It should be something like, more research is needed specifically in this patient group because our review found no trials included them. Or, future studies absolutely must track outcomes beyond 1 year because all the current evidence cuts off too early. Something concrete.
That's the real difference, isn't it, between adding something useful and just going through the motions. A good review uses the knowledge gained to pinpoint exactly what needs to happen next.
Exactly. If the review can't articulate why more research is needed based on a specific gap or flaw identified in the evidence, be it methodological, patient-related, whatever, then honestly, that review hasn't really added much scientific value. It's just summarized what was already there.
So we'll leave you with this challenge. Next time you read a practice guideline or even just a review article, really think about the methods behind it. Were the studies they pooled truly similar? Did they grapple with the differences or just maybe rely on a high I-squared to brush past them? Demand critical thinking in the evidence you use.